Okay, thank you, Dr. Ramalan, for joining right on time.
With an enviable track record,
Good morning, Dr. Manso. Can you hear me? Dr. Ramalan, can you hear me?
Wannan abun me yasa yake da shi?
Good morning, doctor. Can you hear me?
Alfred, come.
Hello?
Your attention, why is it shaking?
I can barely hear you. Please.
No making fun of.
Can you try putting on your video? Be sure everything is okay.
To reach, will it be strong longer enough? Yanzu dai yana yi.
Sir, I can't hear you.
You people, I hope if I come back, you're not complaining that next time.
I hope so, because I can barely hear you down here.
Thank you. What is your name? Eh? Eh? Eh?
It's the kind of it's better than earlier. But you can hear us clearly, right? Or you can hear me clearly, rather. Oh, Dr. Ramadan, are you still there? Dr. Ramalan, we are still waiting for you.
More than 40 years of experience as a legal service provider in Nigeria. OAL has greatly contributed to the jurisprudence in Nigeria. At OAL, we understand that the legal landscape is ever evolving and our clients require not only expertise, but also innovative solutions. With a team of highly skilled legal professionals, we are proud to offer comprehensive legal services tailored to meet the unique needs of our clients. With an enviable track record of more than 40 years of experience as a legal service provider in Nigeria, OAL has greatly contributed to the jurisprudence in Nigeria. At OAL, we understand that the legal landscape is ever evolving and our clients require not only expertise, but also innovative solutions. With a team of highly skilled legal professionals,
engineer.
we are proud to offer
Lafiya kalau.
Okay, doctor.
Yanzu ina ma class.
Okay, I can hear
Ina
you.
class.
Hello, sir.
Amen.
Dr. Ramalan, can you hear me?
Lafiya.
Hello, doctor. Are you with us?
Are you talking to me?
No, ma'am. I was talking to Dr. Ramalan, just trying to
Okay.
check his audio and video. Not sure he's with us yet.
Wani yana gama yau ma kawai. I will just tunda ba kullum nake kwana ba. I will not zan dinga movement ina randomly kawai.
comprehensive legal services tailored to meet the unique needs of our clients. With an enviable track record of more than 40 years of experience as a legal service provider in Nigeria, OAL has greatly contributed to the jurisprudence in Nigeria. At OAL, we understand that the legal landscape is ever evolving and our clients require not only expertise, but also innovative solutions. With a team of highly skilled legal professionals, we are proud to offer comprehensive legal services tailored to meet the unique needs of our clients.
All right. The technical crew, can you conclude the introductory play at the background? We are starting right away. I want to welcome all the speakers, the participants, and all who have joined so promptly. So we are starting immediately. Good morning, distinguished guests, esteemed panelists, industry stakeholders, colleagues, and participants joining us from across the country and beyond. On behalf of Ulisa Abakoba Legal, I warmly welcome you all to today's webinar titled Beyond the Prescription, Navigating Regulatory and Negligence Challenges in Nigerian Medical and Pharmaceutical Sector. My name is Cornelius Oke Gabriel, and I have the honor of serving as your coordinator and compere for this highly anticipated section. At OAL, we have long recognized that the intersection of law, medicine, and pharmaceuticals present not only some of the most complex regulatory challenges, but also deeply personal issues affecting lives, livelihoods, and public trust. So as a forward-thinking firm with a reputation for shaping discourse and influencing reform, OAL has been at the forefront of advocating for justice and accountability in the Nigeria healthcare sector. This we have done either by advising regulatory agencies, government sectors, or even reputable hospitals, or advocating for our clients through litigation, which we have successfully done in the popular case that if you check online, you will see the very popular case of Boju Boma, which will successfully prove medical negligence up to the coroner inquest. So that speaks to why we have the capacity and all the enabling environment to initiate this discourse with a goal of shaping the medical sector in Nigeria. So our work in medical and pharmaceutical negligence litigation, regulatory compliance, and institutional advisory has exposed glaring gaps and urgent needs in our legal and healthcare frameworks. It is this frontline experience that inspired today's conversation. This webinar is not just a discussion, it is a call to action, a platform to spotlight the rising incidences of medical malpractice, regulatory breaches, and systemic negligence, while also equipping stakeholders with the legal tools and insights to respond effectively. So, whether you are a legal practitioner, a medical professional, a regulator, or simply someone with a vested interest in public health and justice, today promises to be an enlightening, engaging, and impactful section. We have lined out reputable and highly qualified speakers for this webinar. First, we have the Director General of NAFDAC, Professor Mojisola Adeyeye, who is the Director General of NAFDAC. Under her leadership, NAFDAC has intensified its regulatory oversight to ensure that the substandard pharmaceutical and unlawful practices are identified, penalized, and prevented, a cornerstone in the battle against negligence and regulatory lapses. The DG today is represented by Oche Abutu, and Assistant Director, NAFDAC. The next speaker is the President of Nigerian Medical Association, Professor Bala M. Audu, who stands as a vanguard of medical professionalism and ethics in Nigeria. His office plays a critical role in ensuring that the healthcare delivery across the country upholds both medical competence and the highest ethical standard. And today, he is represented by Dr. Ramalan Mansour. In order to also balance this discourse with both Nigerian jurisdiction and outside the Nigerian jurisdiction, to be able to look at what happens out of the shores of Nigeria, we have Dr. Benjamin Ochukwu, who is head of surgery, accident and emergency at the Essaouira General Hospital, Al Jallouf, Saudi Arabia, who brings us with frontline insight from emergency and trauma care, an area where swift decision and human lives collide, making negligence costly and unacceptable. His cross-border experience offers us a benchmark for a global best practice. Also, from the academia, someone who has distinguished herself from the field of medicine as an associate professor of neonatology at the College of Medicine, University of Lagos, Dr. Beatrice Ezenwa, who specializes in a field where the most vulnerable lives depend entirely on the precision, empathy, and diligence of healthcare professionals. Here to contribute, her contribution reminds us that even a moment of carelessness can have lifelong consequences. And to moderate this section, this all-important webinar, is our practice manager, Ifeoma Ezenwa. She bridges the legal and policy gaps in the medical space through her dynamic practice in the health law, litigation, and compliance. She will be guiding us through today's conversation with the precision and poise for which she is known for. We are excited to learn from our distinguished speakers, experts who bring rich knowledge and perspective, and we invite you to participate actively. Once again, welcome, and thank you for being part of this timely and important conversation. Let the conversation begin. I hand over to Ifeoma Ezenwa. Thank you very much. Ifeoma, please, over to you.
Thank you, Cornelius Gabriel. Thank you very much to our speakers, and thank you very much to our participants. Just like Cornelius said, the topic of this webinar is Beyond the Prescription, Navigating Regulatory and Medical Challenges in Nigerian Medical Navigating Regulatory and Medical Challenges in Nigerian Medical and Pharmaceutical Sectors. I am Ifeoma Ezenwa. I am honored to welcome you all to this all-important webinar. I serve at Ulisa Bakoba Legal as Executive Senior Associate and Practice Manager. I am a legal professional with a deep interest in the intersection of law and healthcare and public accountability. It is truly a privilege to moderate today's session, where we are going to aim to explore one of the most critical and often under-discussed issues in our healthcare system, and this is medical negligence. Medical negligence, as we all know, is not just a legal term. It is a lived reality for too many patients and families. they are asking questions on what happened to their loved ones. And it is a growing challenge for our healthcare professionals and institutions. As we all know, Nigerian medical and pharmaceutical sectors are navigating through complex terrain, ranging from undersourced hospital, regulatory gaps, and professional burnouts, and pharmaceutical safety concern that is raising public awareness and legal scrutiny. This webinar is not just about identifying what is wrong. It is also about engaging constructively with the people who understand the system, who work within it, and who are committed to change the entire thing. It is about moving beyond the prescription to the systems, the policies, and accountability structures that make or break trust in our health sector. We are extremely privileged to have with us our esteemed panel of speakers who are experts and will be sharing insights from medical and regulatory pharmaceutical perspective. Just as my colleague Gabriel has introduced the speakers, they are experts in this field of medicine and pharmacy. So we are going to go into this webinar proper by beginning to ask the speakers question. So we are going to start with the DG of NAFDAC, who is represented by Mr. Abutu. So Mr. Abutu, thank you for joining us in this webinar. I'll have to start with you. My first question to you now is, I want you to speak from NAFDAC, the regulatory standpoint, to tell us the efforts that NAFDAC have put in place to curb counterfeit drugs, and what innovative strategies and technologies have the agency explored to ensure that drug safety is what is in place and to trace Nigeria's pharmaceutical supply chain. Mr. Abutu.
Okay, thank you. And good morning to everyone on the call. Once again, my name is Mr. Abutu, or Chair Abutu. I represent the DG NAFDAC on this call. She sends her regret. She would have loved to be present herself physically, but for some reasons, she's unable to attend. And so she has asked me to hold her brief in this discussion. Now, to the question. When we talk about safe medicines, like you mentioned, a while ago, medical negligence, as in relation to what we do in NAFDAC. Now, ours is basically about ensuring that the products, the drug products meet standard specification, because that is our mandate. Our mandate, to be clear, is that the product meets standard specification, they are safe, they are efficacious, and then what we do basically is enabling access to safe product, quality product, and then efficacious product. Now, in our sphere of operation, our focus is that the product meets this standard. And when a product meets its quality specification, it is very likely to be safe and efficacious. However, there are certain things that may happen sometimes in the course of production, and then again post-production, that may impact negatively on the product quality and then safety as well, and then whether or not it will be efficacious for those who consume this product. First, if certain good manufacturing practices are not followed, you're very likely to get products that fail to meet the quality specification. So, and GMP would mean that the facility is able to consistently produce products that meet the quality standard, quality specification that we have talked about earlier. So it is not haphazard. It is not that you produce a particular batch, it meets specific standard quality criteria, and then the next one probably will not meet. No, it has to be consistent, and that's what GMP is all about. So for us, we try through adequate oversight and then inspection of facilities to ensure that quality is built into products, and that when consumers take these products, they do not experience failure in treatment. Because for anyone who will take medications of pharmaceutical products, they expect to get results for whatever ailment, whatever disease they're trying to treat. And when these products are not meeting that expectation, then there's a problem. And again, apart from the production facilities where we do inspection and ensure that people comply with guidelines and GMP requirements, for us in Nigeria, for imported products, what we do also is that we have pre-shipment inspectors in countries that are of high risk. There are certain stringent regulatory authorities or countries where products coming from that we may just do some kind of document review. And it is not to say that we do not do full inspection, but sometimes because of the time it may take, and because we know that they have stringent system in place already, we can't do reliance, meaning we just review certain documentation that has been in place in that facility already or in that country already, and then we can adapt and then say, okay, for the reasons that this has been inspected by the facility has been inspected by so and so, we can do some risk-based analysis and then go on to approve, so as to ensure that the product that would be resulting from that kind of registration would not be counterfeit product. And again, when we talk about counterfeit product, again, Nigeria, our legal provision speaks to counterfeit and fake. The standard term is actually substandard and falsification. Substandard meaning that approved product not meeting specified quality standard, while falsified would mean intentionally trying to do something with medical products with the aim, particularly with the aim of just achieving, getting financial gain, not solely because you are interested in the health benefits that it impacts on the consumer. So from that perspective, when we are looking at substandard products in Nigeria, which I mentioned earlier, we just refer to them as counterfeit and fake. That term basically has been sometimes abused to look like brand protection issues, because sometimes in the health sector, what is substandard will not give you the desired result. What is falsified would also not give you the desired result. So what we have done is to deploy cutting-edge technologies to be able to detect these things. We use the TrueScan. The TrueScan is a handheld device that we can use to check products during importation, as well as the products that are locally manufactured in Nigeria. And then we have recently launched the Green Book. But importantly, what we have done recently is to come out with the traceability regulation, which will help us do track and trace of products. And that is a game-changing technology that will help our health sector. Right now, we are trying to deploy fully, but we are running a pilot scheme on it at the moment. And we are starting with products, pharmaceutical products with controlled substance. So that's what we're doing at the moment. And apart from this, apart from deploying technologies and all of that to help curb the incidence of or prevalence of counterfeit medicines, we are strengthening our post-marketing surveillance activities. And particularly when you talk about drug safety is really about pharmacovigilance activities. So while post-marketing may speak mainly to quality of products, pharmacovigilance, to my mind, speaks mainly to the drug safety issues. And so in relation to NAFDAC, what we are doing is to strengthen our post-marketing surveillance activities and then also expand our pharmacovigilance activities, post-marketing surveillance, and then pharmacovigilance directorate. These are two directorates, that tries to ensure that post-approval products still meet the standard specification that they were initially registered with, because we understand that after approval, people may want to be funny. And so we follow up to the market to see how the product is behaving in the market. And then for our vigilance activities, we have what is known as the yellow book. There's the hard copy, there's the e-copy, there's also the med safety app. There's also the med safety app, which people can report incidents of adverse reaction or serious adverse reaction. And this again would depend on the public, because while we are in the same population, we are compared to the number of others outside, I can say that we are a very significant fraction in terms of NAFDAC personnel. And so we depend on the people who actually use this product to report this incident to us. So when you report to us through, and the hard copy of the yellow, or what's the name now? Yellow form. Yellow form is everywhere in our various services in Nigeria. And then you can also access the same thing online. So we take reports from the public, and then when we carry out our investigation, we issue public alert for products that we consider not safe for use, so that the public will become aware of these products and to stay clear from such products. And then we automatically will direct that these products be recalled from the public, from the market. And then there's after we have given that bit of window for it to be withdrawn by the people who probably manufactured them, we will do a follow-up to mop up the products from the marketplace. Again, consumer complaint is also something that we use as information that we receive on how products perform in the market. So with increased enforcement activities, sustained public enlightenment program, and then increased interagency and professional collaboration, we believe that we are doing a lot to stem the tide of counterfeit product. Again, in recent time, what we have done is to discourage the open drug market and then to introduce the coordinated warehouse centers where we can properly monitor products. Kano State is the only state that now has the CWC Coordinated Warehouse Center in Dangoro, Kano. And then we had a lot of fight with the open market dealers, but I think we are succeeding in that area. What we also do is when we have these products, we seize, we destroy them, and then we prosecute offenders who
Mr. Butu, Mr.
Yes.
Butu, sorry, I'm
Yes.
sorry to interject. We would want this discussion to be interactive. Please, can you put on your video so that the audience, the participants can see you and everything will be interactive? Thank you.
So I don't know if you can see me now.
Thank you. Yes, we can see you now. Thank you very
Great.
much.
So I was talking about the trying to discourage open market drug sale, which is a very serious avenue where this whole issue of counterfeit medicines circulate in our market. So we're trying to get states to do, we're in discussion with Lagos State government right now to establish a coordinated warehouse center for the whole of the Dumota traders who sees this product as just regular commodity for trade. They don't see them as specialized product at all. So because we understand the implication of having this kind of product in circulation, we're working with the Lagos State government to have a coordinated warehouse center where we can monitor distribution. Again, for our people, we try to do what we call the hand-holding inspection for local farmer, basically because we understand the knowledge gap in trying to produce this specialized product, which is a farmer product now. We try to help them through the production process, particularly for those who intend to play in the global field, so that, and then who are also trying to aim at WHO pre-qualification exercise. We try to do this for them so that, because as even though the primary purpose for the manufacturer is for them to actually be able to play in the global market by being able to sell to procurement agencies. It also makes quality product available to our population in Nigeria. So we try to do all of those things for them. And then by the time we find products in the market that have not met the quality standard, again, we seize, we destroy, and then we prosecute offenders. Thank you.
Thank you. Thank you very much, Mr. Butu, for the insight NAFDAC is doing to checkmate this product in the market, right from when they are manufactured to when they enter the market and when they get to the end users. So now, Mr. Butu, I want to, from what you have just told us, you said that what is substandard will not give you the required result, which is correct. I totally agree with you. You know, when there is a lapse from the end of NAFDAC, invariably, there will be great effect on the end users who are the patients using this medication. It will bring me to your next question, which is, what are the steps that healthcare professionals and businesses can take to better collaborate with NAFDAC in ensuring compliance and reducing this regulatory violation? Because you have just highlighted what you are doing, but in practice, there are violations. We get to see substandard of fake medication at the counters of pharmacies all over Nigeria. And when medical practitioners prescribe such medication to their patients, we know what will be the resultant effect of it. So what is NAFDAC doing to well collaborate with these people so that there will not be violation or less violation? Thank you.
Okay. On the part of NAFDAC in trying to reduce incidences of violation. We, again, like I mentioned earlier, we try to strengthen our oversight function in terms of largely PMS is the branch or arm of NAFDAC. It's actually responsible for post-approval monitoring. Again, it has to be about monitoring. And then we have to put that in perspective with, I agree with you completely that there are cases of products, counterfeit products, substandard products in the market. Again, we are taking steps relating with the people who, the manufacturers of products. Apart from the production process, which we talked about, trying to ensure that from the beginning, these things meet regulatory requirements or standard specification. What we have noticed basically is that the bulk of the products that you find in the market that are counterfeit, most of these products, they are either unregistered or they are counterfeit of the products that have passed through the registration process. So someone will pick up a particular product that is moving in the market and then place another in another country or somewhere else, or try to manufacture that same product, from another source, and then put it through the distribution system, and then they are found in the marketplace. Now, post-marketing surveillance will pick such product from the market, carry out analysis on these products, either on our own or through reports from a consumer, and then we'll carry through the other processes of ensuring that we get to the source of the product. Recently, we found in Kano a product with zero active oral suspension. It is supposed to be Ampiclox, ampicillin, and clozaxilin 125 each as the strength. And then we found in the market that the product actually has zero active ingredients. So what that means is that the product will not do at all what it is supposed to do. So what we do basically after the post-marketing surveillance officers pick up this kind of product, we issue alerts and withdraw from circulation. In terms of how we relate with manufacturers to ensure that, or stakeholders to ensure that that we reduce the incident of fake drugs in the market. One of the things we do is carry the, first and foremost, PMG Man, that is the pharmaceutical manufacturing group of the Manufacturing Association of Nigeria. They are on the NAFDAC Council, and so we carry them along in our regulations and guideline drafting, and that way they are able to share their experience, tell us exactly how they think we'll be able to get these things done, because again, they have industry knowledge. We have the industry knowledge, but they are practitioners. Some of the things, because of our interest may not align. Sometimes our interest is parallel. Their interest basically is driven by profit. Ours is about drug safety, medicine safety, and so we try to work with them, meeting regularly to discuss compliance issues, and then hoping, and then always encouraging them to present common issues that are common to them, that all of them that they have in common in terms of how to fight this counterfeit medicines that are in our market space. So apart from deploying these technologies that we're talking about, the challenge that we also have in NAFDAC is, again, there's the challenge of manpower, basically, that we cannot run away from that. We cannot run away from that. So being everywhere at every time is not something that is feasible. And that's why we also rely on reporting from the public on where they have found a particular thing or where they appear to be failure in treatment as a result of administering a drug that is counterfeit. We rely again largely on the public to also let us know while we do our bit in post-marketing surveillance. I think these are the areas that we try to collaborate and work with stakeholders to ensure we reduce the incidence of counterfeit medicine in the marketplace.
Thank you. Thank you very much, Mr. Butu. Okay, to our dear participants, while the conversation is ongoing, please drop your question at the Q&A session so that at the right time we'll ask your question to the speakers. So I will be going to the desk of Dr. Beatrice Ezenwa. Dr. Beatrice, please, can you put on your video so that the participants can see you? My question to you, I know you double as an academia and a practicing neonatologist. I know you have burning interest in improving health care outcome of newborn children. So my question to you now is, what are the most common preventable errors in neonatal and pediatric care in Nigeria? And what are the practical measures that healthcare providers can adopt to minimize all these risks?
Thank you very much, the panel coordinator. Good morning, everyone. Good morning, healthcare professionals present, legal luminaries in the house, concerned citizens, ladies and gentlemen. I will start by thanking Olisa Bakova Legal Firm for inviting me to this panel discussion. It is both a privilege and a profound responsibility to address you on a matter that cuts to the very heart of our healthcare system, beyond the prescription, navigating regulatory and negligence challenges in Nigeria's medical and pharmaceutical sectors. And with the cadre of speakers we have here today, I have no doubt that the interplay between established regulatory frameworks and the persistent challenges in preventing medical and pharmaceutical negligence will be thoroughly dealt with. As a pediatrician, I witness daily the devastating consequences when systems fail our most vulnerable. And this matter isn't just about policy, it's about lives that we are talking about. Most often when we talk about negligence in the health sector, our mind is focused on one thing, medical negligence, forgetting that there are many facets of it. Let me start this by reminding us of a sad event that occurred in Lagos about 13, 14 years ago, the My Pikin saga, where we lost over 80 children to an adulterated paracetamol. I could remember how our emergency room and wards were suddenly flooded with children with kidney failure. What happened? Most of them had been given paracetamol or a teething medication to soothe their crankiness or fever. What follows was that they became sick, stopped making urine, developed body swellings, and were rushed to the hospitals. Unfortunately, the majority of those affected children died. One common thing among them was the ingestion of a drug called My Pikin. Further investigation found that the drug was contaminated with an engine coolant called ethylene glycol. That was how we lost many innocent souls. Adulterated drugs, one man's negligence, or what? So negligence is not always dramatic. it is often a systemic failure. We heard the NAFDAC talking so much about it just now. And there are different types of negligence in the health sector. Medical negligence is one of them. It's negligence may be in the form of prescribing errors. And it's very common. In short, it said that about more than 57% prescription by the healthcare provider. It may be, the error may be in diagnostic errors, okay, missed or delayed diagnosis, which is very, very critical, especially in children, where their symptoms may evolve very rapidly. The errors may be in the treatment, wrong medications may be given or wrong dosing, which again is very important in children because before you give a child drug, they are usually calculated based on their weight. It may be due to wrong timing or even unsafe procedures that are being performed. So system failures should also not be neglected because sometimes understaffing leads to fatigue of the staff, and there also may be poor communication between teams, inadequate equipment maintenance. You want to do something, what you used to do it is not available, lack of protocols, okay? All these are causes of medical negligence, and they may all result in loss of lives or severe morbidity or disability. Okay, and then we, apart from the medical, we define the pharmaceutical sector. We also have the dispensing errors. You prescribe one drug, another one is given. The wrong dose may also be given, inadequate instructions or failure to check for drug interactions, and the patient will now be reacting to it. There may be lack of counseling. Before you give somebody drug, you need to do adequate counseling and tell them all the effects and what they will expect as side effects. Sometimes these are lacking, and there may be the beginning of that medical error, because somebody may be reacting to a particular drug. If in the process of counseling, you may find out from the patient that, oh, this person should not take this type of drug, okay? But if you just give the person the drug, okay, this is your prescription, take and go, you may not be able to know some of those things. So let me go back to the question you just asked me. What are the most common preventable errors in neonatal and pediatric care in Nigeria? And what practical measures can healthcare providers adopt to minimize the risk? Okay, so the most common preventable errors in Nigerian neonatal and pediatric care stem from systemic challenges. We cannot overemphasize that. But targeted interventions can significantly reduce this risk. And the top preventable errors and what we can do to overcome them, I will mention some of them. We have the healthcare associated infections, sepsis, infection. Infection is very common in hospitals, okay, and is usually due to poor infection control system, poor hand hygiene, contaminated equipment, or it can be from overcrowding of the wards. Okay, so if we can observe hand hygiene, nearly more than 90% of infections in the hospital can be prevented. The 5 moments of infection control, okay, using your alcohol rub, remembering that before you enter, when you are in the hospital, before you go to a patient, you touch a patient, you must always remember you have to wash your hands or do hand hygiene so that you minimize contaminating other people, contaminating more people, and transferring infection from one person to another. most of the things you do in the hospital, you have to remember that you need to do them under aseptic technique, meaning you have to be mindful that you have to do this procedure you want to do with minimal risk of infection to the child by observing all the precautions you are supposed to observe. Okay, for example, you want to set a line for a patient. You need to know that you need to remember that this line you're setting may be a source of infection. So you try to control for everything that can cause that infection by remembering to wash your hands and doing it under aseptic condition. Remember also that you need to be keeping your environment clean. Everybody can attest that when you go to hospitals, one of the commonest things you see is they're always cleaning and cleaning, okay? Because we know that the environment is not sterile and it has a lot of organisms. So you keep cleaning and disinfecting your surrounding, the environment. We help to minimize healthcare associated infections or infections in the health facilities. Medical errors, like I said before, is one of the commonest causes of preventable errors in the pediatric age group. Okay, and most of these errors come from the dosing miscalculations. As I said before, when you're giving medication to children, their medication is usually based on their weight. So you need to calculate very well that what you're giving is what that child should be getting. There are some drugs that look alike. You need to double check them that you are not missing them. Okay, sometimes the drugs may be poor labeled. In short, there are some in the past, people go to hospital, they give them drug, and then the healthcare provider will clean off the name of the drug. This is not a good, it's not good to do it, okay? Because you have removed it, it no longer has a label, and you don't know who is going to pick up that drug, and they won't know what is there, okay? And that is where some of the errors may come in, okay? So labeling should not be removed from the medication that you're doing. And if you need to dispense that drug without the original container, please remember that it should be labeled so that everybody knows what it is, what it contains. And then we need to, like I said before, when you're giving medication to a child or a newborn, okay, you need to know their weight, meaning that all children, when they come to you, they need to be weighed so that you know their weight. If you don't know the weight of the child, you may not be able to give them accurate, the correct dose of the medication they're supposed to. And a lot of people, when they see a child, they say, okay, this child, I should give him half the adult dose because they think they are miniature adults. That is not so. Every child is unique. And when you want to give them, don't consider them as miniature adults. They are human beings on their own, in their own capacity. And when we are giving them medication, please calculate adequately what you are supposed to give to them. Sometimes to help clinicians, there are some charts that can be that can help you. Okay, we have the Broslow tapes and the age weight charts that you can use. Okay, when you know the age of this child, this is likely the weight of the child, and then you can be able to do that. Is for quick to help you to quickly determine what weight you can use to calculate this child's medication. It's also good to prevent medication errors, okay, to have standardized protocols such that each facility we have for these particular ailments, we are treating, you're treating for infection or you're treating for malaria. This is the standard medication you use, and this is the dose you're going to calculate it per child. For most of the pediatric drugs, you will be hearing per kg per dose. Okay, so which is a standard way of calculating their drugs. It's always advised that the medication you want to give to any child should be double checked. Okay, so you want to be, somebody else may need to check for you. If you want to give something, like for example, you want to transfuse blood, one person can never go and transfuse blood to a child. Somebody needs to help you to cross-check. You cross-check to be sure that what you're giving, that blood is for this person, and it's the name matches the name of the person is going to be given to. Okay, and then somebody checks again to be doubly sure that what you're giving is actually for that person, and it's not for somebody else. In the newborn, in children, okay, another common challenge we do have for them, especially for the tiny ones, is cold, hypothermia. So most of the time is because the delivery room is cold and nobody is paying attention, or there is lack of warming, or the people there, they are feeling hot. So they put on the AC, forgetting that the newborn that is coming has to be putting into consideration. And then they will end up, because the adults are trying to warm themselves up, they want to cool themselves. So they now make the place so cold that the newborn that is coming will now become cold, and hypothermia sets in. And once hypothermia sets in, it cascades a lot of other problems. So the warm chain protocol is very important, especially I'm bringing this up because I'm a neonatologist. I work with the newborns, so I should be talking about them. The warm chain protocol is very important, in which when the babies are born, you dry them because they're coming from an environment that they are wet. And when somebody is wet, you just finish taking your bath, you come out without cleaning your body, you will be very, very cold, okay, especially in the harmattan. So use it to compare to a newborn who came out from the amniotic fluids, the water she has been swimming inside the mother's womb. So when they come out, they are usually wet. And when they are wet and they come out in the cold environment, they will be extra cold. And that's why you need to dry them as fast as possible. And then we now say that you should be putting these babies to skin to skin with their mother, so that they can gain heat from the mother's body, and then they will have warmth. When you're carrying them from one place to the other, you also have to remember that they can lose a lot of heat. And when they get very cold, okay, it cascades a lot of problems. So kangaroo mother care is what you will be hearing most of the time now when you talk about the newborns, putting the baby skin to skin. If you need to carry a baby from one hospital to the another, please, it's safest and easiest for you to carry that baby on skin to skin position and transfer. With that one, you are carrying the baby in front of you on the chest. You can be looking at the baby while you're moving, and then you're providing warmth for that baby. I've seen a lot of babies brought to the emergency room, stone cold. Okay, they are already dead, and somebody was carrying them. Our culture does not carry his baby in the back. It's not helping that baby, because a baby at your back, you don't know what is happening to that baby. So that's why we keep encouraging mothers, when you're carrying babies, please carry them in front, okay? Number one, you can see what is happening to the baby, okay? If the baby is not breathing, you will see it immediately. And your heart that is beating will also be helping the baby to remember, because some of these babies forget to breathe, okay? Your own beating heart stimulates their own to breathe. So carrying them in the kangaroo mother care position, which is the skin to skin on the front, on the chest of the mother, is advocated. We also have other errors that can happen in the newborn, like missed or delayed diagnosis. For example, a lot of people, they don't know, the baby will be there, they don't know that the baby is ill. Or if they know, they don't know what type of illness the baby is. Sometimes the diagnosis is delayed. And these babies, unlike adults, when they're ill, they don't give you too much time to be checking, could it be this, could it be that, okay? So you need to be decisive and proactive in managing and making that diagnosis as fast as possible so that you can be able to manage it. So what am I trying to say? I'm saying that while resources may be, we may be constrained with resources in Nigeria, we still have so many things we can do. Our behavioral change, how do we change to the better and know when something is above us, so we know when to refer. That is very important, okay? We must adhere to rigorous protocols, know what to do. If this baby did not cry, what do we do for that baby? Okay, there must be efficiency in our effective training. Those who are training to follow us in our footsteps, are we giving them all the adequate training that we have all the things that are needed to train them on them, okay, so that they can be able to learn. Strong leadership also in the world is very much advocated. I want to stop finish this question by giving an example of some practical measures that healthcare providers have adopted in Nigeria that have really helped to minimize the risk of death in newborns. I'm talking about, let me give an example of the common ones, like a baby who did not breathe at birth. If you look at the statistics of neonatal mortality in Nigeria, we are one of the worst in the whole world, okay? So the government have looked at it, and anything concerning the newborn is quite dear to the heart of the government right now. And one of the things they have we've done for in Nigeria is to train many healthcare workers on how to recognize a baby who did not breathe at birth and what to do for them, what we call helping babies breathe. So the government implemented this helping babies breathe training and gave it to most of the health workers and the training is still ongoing in so many places. And what was noticed was that the number of newborn that died because they did not breathe at birth drastically has reduced in Nigeria. We are not yet there, but it was better than from where we are coming, meaning that just giving simple training, simple instruction, knowing what to do can prevent a lot of deaths. Similarly, strict hand hygiene practices can cut infection rates in hospitals. And this has proved to be effective. And if these interventions are given, they can help to minimize some of the errors that we see in that causes medical errors in the hospitals. Thank you.
Thank you very much, Dr. Beatrice Ezenwa. Okay, before I continue with you, Dr. Ezenwa, usually at OAL, before webinars are like this commence, we usually take pictures with the speakers. Please, the speakers, can you put on your video so that we can take group picture? And we'll continue immediately after the picture. Ola at the background, please. Can you take the picture so we can continue immediately?
If I'm on, yeah, I'm on it.
Okay. Mr. Ramalan, please, can we have your picture on? Your video. Mr. Ramalan. Okay, thank you very much. Ola, do it very quickly. Ola, are you true?
No, not yet. Please, I will need you to face the camera just for 10 seconds, please, so I can take a good picture. All right. 1, 2, go. Okay, thank you. I'm done.
All right. Thank you very much, Ola. Thank you, the speakers, for the pictures that we just took right now. So, Dr. Beatrice, I'll be coming to you because you raised critical questions from your conversation with us this afternoon, which is going to dovetail to NMA. And I will come to you after I've put this question to Dr. Bala, represented by Dr. Ramalan. So Dr. Ramalan, please, can we have your video so you can take this question? From what Dr. Beatrice said, is my first time of hearing that newborns forget that they breed, that they have to breed. I was shocked to have heard that a baby I have sometimes forget to breed. And she also mentioned what the government is doing to make sure that neonatal mortality is reduced. So on the part of NMA, what specific initiative is NMA doing on their own part to strengthen ethical training for medical practitioners so as to reduce instances of negligence in relation to surgery and drug prescription and administration in Nigerian healthcare system? Mr. Ramalan, you can take the floor.
Oh, thank you very much. I'm happy to be here and representing my president, who will not be part of this meeting. And I want to speak to the topic. Well, the Nigerian Medical Association has been in the forefront of protecting the interests of the patients as well as the service providers. So we have a lot of programs that we have designed over the course of time. One of which is that, the Medical and Dental Council was initially actually the brain of the Nigerian Medical Association. So later it was registered by the government, and later it was promulgated into law as an act of the parliament. So the Nigerian Medical Association was the one that brought the idea of the Medical and Dental Council to regulate the activities of the medical professions. And we also engage our members in regular training and retraining, and we are also part of the curriculum development for medical practitioners. So we are conscious of the fact that our patients are also part of our activities, and over time we've developed a lot of programs to empower, to educate our members. And we have actively participated in some of those laws that have been promulgated in the country, like the National Health Act, which I know actively participated to bring that into fruition. And we are working currently on a lot of things, like the Good Samaritan law. You will know that in Nigeria, currently there is no what they call Good Samaritan law. So if I'm passing around and somebody is sick and I don't know the person, as it is in Nigeria now, if I attend to the person, I do so at my own risk. So we're looking into that and other areas that we have to change the laws to reflect the current reality. So these are some of the things that we're doing at the moment.
Okay, thank you. Thank you very much. So from what you said, and also drawing inspiration from what Dr. Beatrice said, that one of the issues of medical negligence in Nigeria is understaffing, because as it is now, we have a major problem in Nigeria where our talents are running away. So we have an issue of talent flight from Nigeria, and the medical industry is greatly affected. That when you get to some of these facilities, they are understaffed and they are trying to juggle to do a whole lot of things. What then can NMA do with regulatory bodies and policymakers to address this systemic issue of understaffing or inadequate facilities, such as all those facilities, equipment, medical equipment in hospitals like MRI and all that, so that contribute to medical errors?
Thank you very much. I didn't really get to hear you in detail, but I've heard you mention things like medical equipments and...
I can repeat the question.
Yeah, I think I'll be glad if you repeat the question.
Okay, my question is, How can NMA work with regulatory bodies and policy makers to address systemic issues such as understaffing and inadequate facilities that contribute to medical errors?
Okay, thank you very much. We have been working in several areas. One is that we recall that the Nigeria's budget for health has always been falling below the expected standard. You know, there was this Abuja declaration that recommends that 15%, at least 15% of the national budget should be allocated to the health sector. But in the 2025 budget for Nigeria, the health sector was allocated 5.14%. So this is less than 30% of what the Abuja Declaration actually stipulates. That is number one. Number two, we know that there is inadequate manpower. And the worst of it all is that the scarcely trained manpower that we have are leaving the country due to poor working conditions. And we are working on that aspect to ensure that the government actually does some programs of welfare and increase what is available for welfare for doctors so that we retain them in the system. We are also working with the government to ensure that certain things like the medications now are very, very expensive. So when they become too expensive, there are chances that patients will not be able to get them, and there are chances that the counterfeit ones will be more available. And there are instances where I myself, when I try to prescribe some medications and I think that the patients cannot afford, I get in a difficult situation. So these are areas that we are working with to ensure that that has been taken care of. And like I told you, we on the Council of the Medical and Dental, Nigeria's Medical and Dental Council. Unfortunately, some of the challenges we are facing is that even now, as we speak, the federal government has refused to inaugurate the Council for Medical and Dental Council. They just appointed the chairman. I think it's sad because people have avenues to assess remedy in case that they experience medical negligence. And one of which is through the Medical and Dental Council, and the other is in the courts. And now you have a Medical and Dental Council that is not inaugurated by government for reasons we don't know. We have complained, we have talked, we have shouted, but the government doesn't appear to be interested. And it's sad because you have a council that is supposed to provide support to patients in case they experience medical negligence. And that council is not inaugurated. They just appointed a chairman. And a chairman in a council of over 40, 50 people, cannot be able to exercise the power or authority to do what is expected. And the working condition currently is terrible. Quite a number of qualified and well-trained doctors have left because the government needed to do a lot of things to retain the manpower that is currently in the health system. As for the facilities, we have been having a lot of problems with obsolete facilities and even sometimes lack of appropriate facilities. That has to do with the challenging environment, the poor economic situation we find ourselves, and even the attitude to government to some of those issues. Government sometimes, when they procure some of these equipments, they are not done with guidance or input of experts. So some of these things are the reasons why we're having these challenges. But the enemy is constantly working to see that there is improvement in some of those issues. That is not to say that there are no improvement. There are some improvement in some of the indices, but as it is, we need to do a lot more to retain our staff. We need to do a lot more to provide the necessary equipment and environment for people to work.
Thank you, Mr. Butu, for your insightful contribution. Thank you very much. So I'll have to come back to Dr. Beatrice. Dr. Beatrice.
Okay, I can hear you.
Oh, yes. Okay, Dr. Beatrice. I'll come back to you again. During your presentation, one of the things you said was that the wrong prescription contributes to issue of medical negligence in Nigeria. And Mr. Butu also made a statement that what is substandard will not give you the required result. So it comes to my next question to you, because I will not forget what you said, that newborns, they forget to breathe. I've never heard it before. So now my next question to you right now is, in cases where adverse drug reaction occur in children. Before I continue with this question, let me give you a background to this question. There's a life issue where a newborn was given more than 20% or 40% of paracetamol that she was supposed to be given in a facility in Nigeria. What I am saying is that I'm very sure that a newborn should not be given more than 2.5 ml of paracetamol, or sometimes 1.5 ml of paracetamol. And now a newborn baby was given well over 180 ml of paracetamol that made the newborn to go into acute liver problem. So this is the background to this, your question. So in this case of adverse drug reaction, when it occurs in children in Nigeria, especially neonatals, how can pediatricians protect themselves legally while ensuring that families still trust the healthcare system?
Thank you very much once again. This is a nuanced question that blends medical ethics, legal risk management, and patient communication.
Yeah.
When adverse drug reaction occur in children, especially in the fragile neonates, balancing legal protection with maintaining family trust requires proactive communication, meticulous documentation, and patient-centered transparency. So health workers should know that legal protection starts even before that prescribing. Okay, so before you give somebody any medication, you must have gotten a consent that, oh, this is what I'm going to give. You must discuss the known risk of the medication that you know. This drug that I'm giving, on your case, you said paracetamol. This paracetamol that I'm giving, okay, if it's known to cause severe rash or even liver damage, okay, so they will have known, or you have brought it to their notice before what you're about to do. Okay, of course, you are not planning that this particular child is going to have this reaction. But what you are asking me is, your question said is that somebody gave more than 20-40% overdose of what is supposed to get. Okay, so when you were doing the prescribing the medication and giving it before, you were not thinking of the overdose, but you are just giving the basic, doing the basic things you are supposed to do when you're giving medication to somebody. You need to discuss with them the risk, because there is no drug that doesn't have a side effect. What happens is that the benefit usually outweighs the side effect the drug is going to cause, so we say we should give it. Okay, but there is no drug that doesn't have a problem. Okay, and some problems can be idiopathic. I mean, that's patient A had the side effect does not mean patient B will have it. But in the case of overdose, okay, this you have given more than the regular amount that that individual is supposed to give. So some of those things you explained in the beginning may occur to that person because you have actually given more than what is supposed. Okay. However, in that initial process where you were discussing with them, okay? You've gotten the informed consent. You've got the know that, okay, you are going to give this drug. You need to document that conversation with them, including, because sometimes you tell the caregivers that, okay, we want to give, let's take, for example, somebody, I'm going to give chemotherapy, a drug for cancer to these patients. Okay, you need to explain. Okay, sometimes in the explanation, they may hear that, oh, you give this drug, the patients will lose their hair. Okay, and some of them, that may be their worry. They will not ask, doctor, why do you want to, can we give something else? And you tell them, no, this is what this illness will require. Okay, so you now give it. Okay, you've already made that conversation, and you need to document that these are the things, these are their concerns when you told them the side effects. You need to explain things to them in simple language. So we know that drugs in children are usually given based on their weight. Okay, so before you give drug, you must cross-check and know the weight of the child, and cross-check that the drug you're giving, the dose you're giving is actually the dose, the proper dose. Okay, so you must double check that before giving that you are giving the correct dose. So if inadvertently you now give the wrong dose and adverse drug reaction occurs in that child, what are the things you need to do? Okay, the first thing is that you must prioritize care for that child, and then you must be transparent. Okay, because your transparency acts is also very important. How do the parents or the caregivers see your actions? Okay, so you must act fast to stabilize the child first. Document your interventions. What did you do, okay, that you stopped the drug? For example, let's use a practical example. Assuming, okay, this one you said they gave paracetamol. Okay, so the next thing is that, okay, if that paracetamol was like in an infusion, so it's still ongoing, you need to stop the administration of the paracetamol immediately. And then, because when somebody has adverse drug reaction, sometimes they can go into hypotension. You need to remember that you have to set up an IV, a fluid to help to maintain the tension, so that the child doesn't go into hypotension. Then you also need to be seen by the caregivers to be to actually be aware of what you are doing, what is happening. So you need to disclose early and in a compassionate manner to the caregivers. Your child had an unexpected reaction to the paracetamol. We are investigating to know why and adjusting care. So you need to be seen to carry them along and explain to them what is happening. There is no need to, you shouldn't be blaming anybody. Okay, there is no need going there to say that the pharmacy gave us the wrong dose or the nurse mixed the wrong dose and I just have to, no, don't be defensive, okay? There is no blame game there. And of course, don't also the doctor shouldn't be making conclusions prematurely, okay? Because at the end of the day, like I said, some drug reactions can be idiopathic. It may not be because she has given overdose. It may be because that person is reacting to it, not because of overdose. So you can't quickly decide, okay, it's because of that he gave 20 milligram more than required. That was causing it. No, don't be premature in making conclusions. It has to be fully investigated. Okay. And of course, you need to apologize to the caregivers and the patients for the experience, but not negligence, because you have not investigated it. We are with the lawyers, and one of the things they keep telling us is that, you are not guilty until the judges says it. Yes, so but you need to apologize for the experience. The child is actually having an obvious reaction. So you need to apologize for that experience, but not that it's negligence because it has not been concluded. And simply say, I'm sorry, your child is going through this. We are committed to helping them recover. Okay, so that will build trust with the family without you admitting liability, because you cannot, at the heat of the moment, agree that you have done committed an error when in fact it may not be an error. It may be just that child that is reacting. Documentation is very important. We cannot overemphasize it, because when it comes to, if that case actually gets to the law court or gets to a panel, it is what you have written down that for us in the medical field, whenever you have interaction with patients, it's usually documented. So when they're going to look at that case, it's actually what you documented that is going to be your witness. Your witness is not what you're saying at that time again. It is what is documented. And anything that is not documented is not done. So we keep, even from medical school, we keep telling our students, our doctors, that you must always document. Whatever interaction you had with a patient, you must put it down. Because when it comes to, when they are x-raying it and looking at it, and then you are facing a panel, you cannot remember what happens. You have a doctor in a day can see more than 10, 20, 30 patients in a day. How are you going to remember what happened between you and this other one? So if you are not documenting it, okay, so document every detail, every step of what happened. Indication for, you need to tell us why was the child given that drug in the first place, okay? What was the dose that was given, what was the route, and what frequency, okay? And what monitoring parameters we are put in place. Were you monitoring the vital signs? Okay, did you check the some parameters in the child? For example, you're giving drugs that are known to cause liver failure. Okay, did you check the baseline liver function of that child before you started that treatment? Okay, so did you, some of these things step by step. So if you follow the appropriate protocol and the guidelines, okay, even when the child has adverse reactions, it may not be because because of your faults, okay, it may just be that child is one of those who can have adverse reaction from that drug. Okay, so when you're documenting your adverse reactions, or what some of the things that is important is the time you are also making that documentation. Okay, when was this drug given? At what time did the child develop the reaction that was noticed? What was it that was done? Okay, so we will now go back and be looking at all the things that you have documented. What was the severity when you noted it? Okay, and all that. What was if you try to do some, give some ameliorative drugs, like you set up an IV line, like I said before, so that the child doesn't have hypertension. What did you do? Which drug did you give? And all those. So those ones are going to be very important when you're documenting, because like I said, when you're going to face the panel or you are in the law court, some of those things are what is very important. Then how did you carry the family along? You must communicate. You don't hide that, oh, this child has suffered some adverse drug event because you have given 20% extra for that paracetamol. No, you must discuss it with them. If you're a junior doctor, you may need to call your seniors, okay, for them to come around and then help in knowing what to do. You must communicate with the caregivers, the parents. Most of the time, the caregiver in pediatrics is actually the parents, the mother, the father, or whoever family relative that is there. So you need to discuss that reaction with the parents and explain the likely cause. What are the next steps? What do you want are we going to do? And listen to their questions. So they may have some questions and then you give the answer to the best of your ability. When adverse events happens, okay, it usually becomes a learning point. Okay, because so that something like that won't happen again. So in the wards, somebody gave an overdose of paracetamol. Okay, why did that person give overdose of paracetamol? You must in-house find the root cause of that, why the person gave overdose. Is it because the person was overworked? Is it because the person cannot see? Okay, or is it because what happened? Why did they give over? So you must do the root cause analysis, because if you don't do the root cause analysis, you may not be able to prevent it occurring again next time. Okay, so you must do the root cause analysis. You may need to even involve the family. You need to tell them that you're reviewing what happened, okay, to prevent future risks. Would you like to share your perspective? Because sometimes in the wards, when the parents are there with the child, they may actually be the one knowing what happened. Okay, even before the healthcare provider recognizes it, they may be the one that raised the alarm first, and they may be the one to recognize the reaction that is happening in the child, how the child is having their reaction. So you need to find out what happens, document all of them, and then use it as a training for future, to prevent future occurrence. Let me just say something about this. I've had, of course, in the wards, you keep on getting series of these experiences all the time. I had a one time, some years ago, a patient, a newborn. Okay, one of the doctors was trying to set up a line on the child. Okay, the child, the line, they need to give drugs to the child, and they need to get access into the intravenous routes. The baby's line was off, so they couldn't give the drugs, and this child is not eating, so had to depend on IV fluid. So that line is an important one, an emergency. And that night, the doctor that is on call had almost more than 30-something babies to be looking after, and they're all ill babies. So she's running from one place to the other, from one cot to the other, trying to look after the baby. But this child whose line has gone off, she needed to set that line, because if he doesn't set the line, the child the sugar level will just go down, and then they will be managing something else again, on top of all the problem they have. And like I said earlier, newborns are what can take adults days or even weeks before they show symptoms, a newborn can show symptoms in minutes. It's usually emergencies when they have issues. So this doctor now went to set the line for the child. Okay, when you are setting line, usually for you the vein to come out, you usually tie a tourniquet, so that it will help the blood to get engorged in the vessel, and then you can be able to see it faster. And this was what she did. He now tied the tourniquet. And when she finished, he forgot that he kept that tourniquet that he tied. And when you tie the tourniquet, you are actually, why the blood, the vessel become visible, is that the blood is trapped, so it doesn't flow, allow it to flow back as easily as before. So when she tied the tourniquet, he finished setting the line, he forgot that the tourniquet was there, and then he left. And the baby was with the mother. So he faced other call duties he was doing and running up and down. That doctor did not sleep that night. And incidentally, the parents of the babies in the ward, we are seeing him, and saw how he was working, that he was trying to attend to everyone, and they could see that he was actually working very hard. So early in the morning, when it's time to give that child his routine medications, when they come to give the medication, they found out that the hand was swollen. Okay, and that was when they noticed that the tourniquet that was tied on the hands was not removed. Okay, and the hand of the baby was like 3 times the size because of the swelling, and this drew alarm. The father came. The father was wrecking mad, and everyone. So by the time we were called, we came, and the father was. There is one thing that the father kept saying, that how he wish is not that doctor that did this thing. And I asked, why are you saying? He said that this doctor was so compassionate. The doctor was trying to do everything, that the way this doctor worked, that he was even complimenting him, that how he wishes somebody else so that he will escalate this problem anywhere. Okay, but because of the way the parents perceived the doctor, that he was a compassionate one and was following up, okay, they didn't raise the issue higher than it's supposed to be. And that is just to tell us that sometimes it's actually how you address the matter that will determine how how it will be escalated to. Okay. The trust that is preserved is through honesty. They could perceive that this doctor was doing all he could for these tiny babies all through the night, okay? And the meticulous care he was taking and turning, and then the way he was carrying them along, okay? So that threw the father off, and he was lamenting that, oh, if it's somebody else, okay, the things I could have done, but because the way the doctor carried them along sort of disarmed them. Okay, so what this is telling us, that trust is preserved through honesty, our meticulous care, and turning adverse events into systemic learning. Leaving that tourniquet became a learning point. Okay, everybody has to know that. Please cross-check. Once you do, and let's cross-check again. Why that one happened was that the child was wearing clothes. So when she finished, the tourniquet was under the clothes of the child. So they couldn't see the whole hand for them to notice it. So that the whole night, nobody noted it until early in the morning when they want to give the routine medication. So once again, let me just say that for a healthcare provider, your best armor is documentation that proves that you adhered to the standards, and that you are also compassionate in your engagement with the patients. Okay, that shows the families that you actually value them. Okay, when errors are made, and for example, in this dosing, or in that case that I presented, the person that sets a tourniquet and forgot to remove it. When errors are made, immediate disclosure and accountability, paired with corrective action, often prevents litigation more effectively than if you cancel it. So if that person has considered, I don't know, it's not me, or start blaming people, okay, it will have been escalated. Okay. Errors can be made, but how did we manage it? That is the most important thing. Thank you.
Thank you. Thank you very much, Dr. Beatrice Ezenwa. Thank you. Empathy is key in everything, because many people have said that some doctors don't have empathy on their patient. I see that's the reason why if there are issues of medical negligence, those patients tend to take it up. So I'll be coming to Dr. Chukwu. Dr. Chukwu, okay, your video is on. I'll be coming to you, drawing from insight from what Dr. Beatrice said. You are from Saudi Arabia, working in Saudi Arabia. So you are going to take us through what your experience in Nigeria and that of Saudi Arabia. So your question now is, drawing from your experience in Saudi Arabia, and given the fast-paced and high-pressure environment of emergency care, how do you handle cases where patients and their families allege that delay in treatment at the emergency and accident leads to avoidable death or complication? Dr. Chukwu, can you hear me?
I can hear you.
Oh, thank
Hello,
you very
can you hear me now?
Oh, yes, I can. Perfectly.
Oh, all right. Thank you so much. Thank you for the opportunity to be here. I am Dr. Ben or Benjamin Chukwu. I'm a general surgeon. You said I'm from Saudi Arabia. Sorry, I'm from Nigeria. I'm a Nigerian,
Yeah, in
full-blooded
Nigeria.
Nigerian. Yeah. Yeah, I work in Saudi Arabia.
Yeah.
And I want to thank OAL for this opportunity. I've always admired your boss, so I didn't hesitate to accept to appear on his platform. Thank you so much. I also want to
Welcome.
thank all the viewers. I want to thank all the viewers and my friend, Cornell. Thank you so much. Yeah, you said something. Before I dive into your question, I would want to state something very clearly. You see, everything we are saying here today, if you remember all that the NMA chairman said and what Dr. Beatrice was talking about, I'll tell you, we can summarize everything they have said and end it up with systemic failure. Whether it is a negligence that occurred because the doctor, just like Beatrice said, maybe the doctor did not see well. That is what led to the error. Or maybe there was something not available. Or maybe the protocol, hand washing protocol she mentioned, was not done. Infection will come. She rightly admitted the impact of infection. And for us surgeons, actually the worst thing, because surgical site infection is actually the leading cause of death globally, not just in Chile. So, but you see, you want to follow that protocol and you don't have tap running water available, systemic failure. What happens? You don't have the alcohol hand scrub. What do? Patient is standing in front of you. You must do something. You end up doing it anyhow. That is what we see in Nigeria. So if I am to compare the medical sector in Nigeria with any medical sector elsewhere outside Nigeria, including Saudi Arabia where I am, you will see that there are reasons why Nigerian citizens must do something about the system. And Nigerians public should do something. I have to speak like this because, be honest with you, when you practice outside Nigeria, you become very angry with those leading Nigeria and the system in Nigeria. Because you ask the question, if somebody complains that delay in attending to his patients led to maybe an unavoidable complication, which is what we call morbidity, or mortality of the patient, which is death. If this happens, how do I handle it? I won't have any interface with those people. They will not complain to me. They are empowered. They have the knowledge. They have a number. They will just simply call. So I'll be addressing your questions this way, please. So bear with me. So they have a number to call. There is no way of coming to the doctor. Your delay caused this. It will happen. It can only happen in Nigeria. A patient or the relative will not come to me and say, I am the cause of this problem. No, they will just pick their phone and send a call through a number, a unified number. And that number, somebody is there sitting on the other end to receive it immediately and call the management of the hospital. And based on what the management of the hospital will immediately initiate. And he doesn't need to come and ask you anything. He will just scroll. The monitors, the CCTV cameras are there. They are everywhere is under surveillance. And they will begin to check what happened, what time, and they will check everything that happened in the emergency. So where do I need to come and communicate? Why do they need to call me? They will know whether I was sitting around drinking water or gisting or pressing my phone when the patient was brought, or whether I was busy attending to another patient. And then the triad did not do their work. So this scenario actually happens in Nigeria. It doesn't, most of those scenarios that we see actually do not happen elsewhere because the places are sane. Nigeria is insane. We need to be honest about it. So, sorry, I know this is a global platform that can be aired globally, but we need to be honest if things have to change. We need to be honest if things have to change. Things are not working well in our system. People are working. See, getting back to your question, so I've just in a nutshell told you, they won't come to me, they will report through a number, and the number, it will be investigated. There will be no subjective influence. It will be purely objective because they will see clearly. If the time they'll get to you to know that the report has been made against you would be after they have checked everything, documented their things, then they'll invite you just to give you that fair hearing. If you are found guilty in here, that's where they will come to you and they'll say, okay, why did you do this? And then you can explain. Also, this same doctor who is making the error, have you checked the situation? I was in Nigeria. Let me say this before I continue so that people understand. Make some examples, people will not tie down to somewhere. I worked in Nigeria. I started my training in Enugu. I moved to Calabar. I moved from Calabar. I went to Lagos. I was in Lutz. From Lutz, I went to OAU Teaching Hospital. I was in OAU Teaching Hospital. I came back. I was in Enugu again, initially from ESU Teaching Hospital. So I have gone through Nigeria's system and I've seen what it is. You cannot tell me that before that, I was running my private hospital. So I had done private hospital practice before going into residency training that now took me around Nigeria, virtually all the zones. I forgot to mention at a point, I also, for a little while, I was in Zaria. So when you look at all these things, I have seen firsthand what Nigerian health sector is like. And I can tell you sometimes I think my people, my doctors and other health workers, as though they are magicians, because the same circumstances presented that they are working under, if you give the same circumstance to other people elsewhere, I tell you, maybe people will be dying in droves. However, let me add to what Dr. Beatrice said. I actually formed a scenario to cut down issues of negligences. I created a principle and I call it the D4 principle. Carefully, with detail, what your interaction or interface with patients are, you will hardly have a problem, because as you're documenting, it is reminding you, oh, you've not done this, you will do it. And you must document timely, not wait till after 2 hours, you know what patient has gone, you now start documenting. You must see a patient and immediately document. Now, the next thing is the compassion. When you're a compassionate doctor who shows a lot of empathy when relating with the patient, when talking to the patient, when dealing with the patient, you must show compassion. It is that compassionate demeanor that will make you, if you're hungry, your hunger pangs will switch off. They will go on strike. Immediately you hear that there's an emergency case. You will forget about food until you have finished attending to this patient. It is the same thing that we hear, oh, I want to travel for a vacation. I want to go to and you hear somebody is sick. You will switch off, all that will switch off, and you are focused on attending to your patient. And when patients see how passionate you are in caring for them, to be honest with you, even if you make an error, just as she also mentioned, they will be the one pitying you. Have you ever seen a scenario when a patient died and the patient relative, the father, the mother, come to you and tell you, doctor, sorry? That has happened to me a number of times. Doctor, sorry. Imagine you lost the patient, you've done all you're supposed to do, but the patient died. And the patient relative turns around to you and tell you, doctor, sorry. That is the scenario that you have when you are a compassionate doctor. Then the next is competence. Do you continue to go through training? Do you try to keep yourself, do you acquire all that you need to know? You see books on your medical field, do you continue reading? And then during your training, were you cutting corners? Because one of the things that happen in Nigeria is that people like to cut corners, not only in Nigeria, in many places. But when you are somebody who in your training time cuts corners, you will find out that along the line, you will not know so many things you ought to know. You may be lucky and you scroll through the exams and you pass, and they've appointed you. But when it comes to the real practice, you continue to commit errors. And these basic, simple errors, like we are talking about, somebody wants to set the line. Let's say everything is even available, and you are setting a line, and because you did not observe certain protocols, you ought to observe the aseptic protocols. In fact, I must honestly say also again that even when you want to observe all the protocols in Nigeria, it is impossible, because they will tell you there is no sterile drip. and you are no more doing any aseptic protocol. So in all the protocols or all the global best practices that are developed by WHO, by CDC, by all the global world and are observed internationally, when you want to practice them in Nigeria, I tell you the truth, you are in trouble because you need to wash your hand, tap is not running. You want to set line, the light is not on, and you're using phone light. To be honest with you, I can't count how many times in Nigeria I operated with phone light. Let anybody go and ask any resident surgeon how many times they use phone light to complete surgery. I can't count the number of times I did that. You will have to be both a doctor, a surgeon in Nigeria, be a generator inspector, be a lab expert, be a oxygen plant monitor. You have to go around all these places. I see Nigeria trainee doctors, surgeons especially, because when you are to do one case that ordinarily I will sit in the office, wash my hand, walk in, patient is on table, prepared, and I will pick knife and begin to operate, and within minutes I'm done. That is what will happen elsewhere. In Nigeria, to prepare one patient and take him to surgery, you have to check everything. There may be oxygen in the pipeline when you're about to start the surgery, but the next thing you notice is that halfway in the surgery, the oxygen has finished. And because you did not go to oxygen house to find out if there was enough oxygen for you to start the surgery, everybody will turn around and blame you. But that is not your job description. It's not what you're called to do. That's not your duty. Somebody is paid, employed to do that. But because maybe he's a relative or is a junior staff employed from quota or this, he doesn't care. He comes and he leaves. And then you cannot, he's not doing his work. He's not, then they turn everything on top of you, the doctor. The same thing, I don't know. In fact, in this discussion, I don't know where to start, because if I begin to talk from my experience, I will be very passionate, and I may point at things that people do not want to say because they are working in a Nigerian hospital. And those are the things that are destroying the health system. When I talk about the anarchy that is in the system, where you have multiple regulatory bodies, you have the MDC and MDCN, doctors, dental surgeons practice. You have the Nursing and Midwifery Council, you have the Pharmaceutical Council, you have several, and they are not working together. And then when there is a problem, you, the doctor, they say you are working in a team, and you don't even have a say to what the nurse will do. But if the patient dies, you are the one that will be held responsible. So there's a lot of anarchy in the health system that needs to be streamlined. So if we continue to speak all the grammar and we do not fix our government and we do not fix the system and do not fix the regulatory bodies, we will end up speaking grammar, and going back, it will continue, because most of these errors that occur, they occur because there is something somewhere. When I talk about the systemic corruption, these are the things, and these things are not seen where I practice now. So when you look at those corruptions that made somebody, see, I don't know if I should mention this. You have a system that is created. There is a hospital, and they created a hospital board. And this board is sitting in Abuja or different places, only to visit the house maybe once in 3 months. Those are the monitors that are supposed to supervise management of the hospital to ensure that your teaching hospital or your specialist hospital is working well. What do? In that, as they are visiting in that once in 3 months, the whole hospital is drained. The hospital is empty, no money to buy drugs. Do you know why? The CMD is waiting to please the team that represents the hospital in Abuja before the presidency. So they will mobilize money. All the money given to them will be used to settle the board members, and the chairman must get everything he wants. What they come is to come and pack the resources that you need to run the hospital and provide what is needed. My brother here, the NMA representative of the NMA chairman, Dr. Balas, said that, you see what he said about the MDCN and what was going on. You discover that he mentioned also about the amount of money that is budgeted. He said it's 5% of the budget, 5.1. It was 5.8 during the time of Buhari. This person now has made it 5.1. And now that money is supposed to be divided into 3. 1 for capital project, about 40%, about less than 2% for about 60% for salary and wage staff. Even the 5% that is getting, how much, and if it gets to how effective in track, how the money want to share the money, because of it, there are no resources, there are no equipment. The hospital outside and the hospital in Nigeria, you now see a place that is dry, no facility, no light, no water, no bushes everywhere. And you now look at the hospital in Nigeria, in X-ray, you see a very clean environment, like a clean room environment, and you see everything sterile. Everything is in package, everything is ready to use, everything is there. So everything you need is available. Then you now look at the workforce. How much are you paying? You see a doctor in Nigeria, his counterparts elsewhere are paid 10 times or between 10 to 20 times what they are paid in other words, in 10 to 20 years, and somebody will have to work in Nigeria to be able to get 1 month's salary of his counterpart elsewhere. They pretend about this, but it's a fact. Nigeria is not treating their workers, not just the doctors, their workforce, whether it is the nurses, the pharmacists, Nigeria is not treating them well. And all this money is being stolen by a group of people who steal the money, and they will tell you they have used 63 billion to renovate a house and use the other one to maybe 20-something million to dig 1 borehole or buy 1 street light, and Nigerians are seeing it. So if we need to change the scenario in Nigeria health sector, I want to advise Nigerians to rise up and face the reality. There is nothing that can be done until the system is fixed. The day Nigeria will be okay, will be well, things will work, is once we get a sincere, honest leadership that is ready and that is ready to sacrifice for the people and is not ready to steal. It is only then and then alone that Nigerians say, because see, the chain is from Abuja to the board. The board will collect their own to the ministry. The ministry will collect their own. The board will collect their own. The board will now go to the hospital because they have settled the board. The hospital is empty. The money is gone and nobody will supervise it. So let me look at your question once again. If they report that there is such a thing, what will I do? If they report this, following the channel of report, and it gets to me that, oh, I made or somebody working in the emergency committed an error. The system is clear. The litigation process is very fast, unlike Nigeria, where it will take 2-3 years before you can establish a case. And I understand why it is so, because when you don't have monitoring, when you don't have surveillance, you can't get incontrovertible evidence. So evidential problems is an issue. So, and you cannot decide your case. And sometimes corruption will make settlements from different places. At the end of the day, you can get, but this one, the patient will definitely get justice, will be settled if there is a proven case of negligence, because the system is clear, evidence is incontrovertible, because there are technology monitoring everything. And then in the system, see, even when you want to handle a case in Nigeria, you'll be looking for folders, files with papers over more than 100 papers, only held with a file tag. And many of it are torn off. So when they document, what kind of document? We need to adopt the global best practice, which is EMR, electronic medical recording system. We need to adopt it and begin to, so that once the patient comes, see, there will hardly be such delay in the first place. In the number of years I've been in a particular hospital here, I have not gotten a story one like that, and nobody has ever complained that, oh, because of a delay. Why? Because the reception is just facing the door. There are 5 ambulances steaming and waiting outside, and their drivers are sitting by them. And then you now have a patient brought in immediately. A bell is pressed, all the people that needs to be there is brought in. They are already on ground waiting, and everybody is doing what he's supposed to do. So where would the delay come from? And why are they motivated to work? Why is it like so? Because the monitoring is there, because the system is well structured, that there is no loopholes. Our own is filled with loopholes. And these loopholes, some of them are intentionally left there because some people do not want to be caught doing the wrong thing. So I don't know if there are more things, maybe if I have addressed your questions, because there are things to say, but I don't know where to start because there are too many. Thank you.
Thank you, Dr. Thank you, Dr. Chukwu. You have just laid everything there as it is. I totally agree with you that we have systemic failure in Nigeria and we need to address it urgently. Okay, I would want you to answer this question very quickly because we are running out of time and we would like to take question and answer. So, Dr. Chukwu, my next question for you is, you talked about Nigeria has to meet a global standard. in everything we do, so that when a patient comes into a hospital, there are people, medical doctors, there are even nurses, pharmacists, and anesthetists that will be attending to the patient, especially when the patient will be needing surgery to address an immediate need. So how can Nigerian surgeons incorporate these international best practices to reduce surgical complication that might lead to the death of their patients despite resources constraints?
All right, thank you so much. Despite resources constraint, well, it's like asking me, how do you hydrate a person when there is no water? That's actually what it looks like. However, I don't know if I'm audible. How do you hydrate a child when there is no drink?
You are audible,
Yeah.
sir.
So it's like asking me, how do you put on fire when there's no extinguisher and there's no water, there's nothing. So, however, that's why I said sometimes when I look at this in Nigeria, actually look like they are magicians. Why? The global best practices, let's start from infection control. In infection control, the basic thing is that you have to wash your hand. Just ask any doctor you know. How many times in a month does it happen within the hospital? So, and does it mean that the patient has to come in when the tap is running? Or you have to employ another person to stand by and use cup and be scooping water from a stagnant source, bucket that you have kept and in fact bacteria has grown in it? It's no more hand washing. What is recommended is a running water. So when you have a bucket and the container stagnant there, it is no more the same. It defeats the purpose. That is one. Then that is just the simplest thing. I am not going into so many other things. For you to reduce infection, the basic thing most surgeons and anesthetists know is that you have to do the surgical checklist. So you must start your patient even from pre-operative preparations to when the patient is even in the OR, just before the surgery, you do all the checklists, and those checklists are not things I'll start, but they are just in 3 stages. They are not things we go through, but doctors know about this. They can only be practiced in some teaching hospitals or specialist centers, federal medical centers. It can't be practiced because in these ones, relatively, some of the facilities are available. But have you considered that the Nigerian health sector is far beyond the tertiary level? Not even all teaching hospitals can practice that. It's far beyond. Let's go to the real thing. Even in the public health sector, the entire primary health sector is gone. All the health centers and general hospitals that are secondary are all gone. They are non-functional. So nothing can work when facilities and materials are not available. So water, basic water, that all countries that reside in the deserts, have already dredged water from ocean very far, like hundreds of kilometers or thousands of kilometers. They have filled their lands with water. But Nigeria lives in the midst of water, yet you can't find water running. So that is one. So how do you prevent infection? And you must do operation on an emergency patient that was brought in when there is not even the water to wash hand. Occasionally they may have. Let's assume today that there is water. Now the next thing you get in, and they said, okay, one of the checklists is that the sites for surgery must be marked, identified. And ordinary marker, skin marker is not available. What do? You improvise by using, if it's chalk, which is wrong. So what do? You just carry it in your head. That's the surgeon. I'm giving you exactly what it looks like. Then you get to the next. They'll say, okay, this patient must wear a tag that defines identity and everything. So there'll be no error. And the patient goes, okay, let's say that we have finished that level and everything is okay. We've crossed there. Oh, we are lucky today. All these ones are over. We entered into surgery and there was light on. Everything was going normally. Halfway in the surgery, lights off. And they wanted to start generator. Generator refused to come on, which is very common. What happens? Everybody around, 3-4 people, will now put on their phone lights. Phone. Maybe there's rechargeable that has gone low because it was used in the night and it has not fully charged, or rechargeable lantern. And these are not standard practice. When you use phone light and you focus, and this patient eventually, you are talking about negligences, and this doctor eventually left a piece of gauze inside the abdomen. That could be the end of that patient because the gauze is inside, or the towel, the anything, or even instrument is left inside that abdomen. And the patient recovers that the acute period and goes home. After a month, he's having some pain. The abdomen is infected. Surgical site infection has developed. And in fact, he's even causing adhesions and he's getting intestinal obstruction. He's not able to, if he eats, he cannot go to the toilet. If he eats, he's not vomiting and so many things. Patient becomes a chronic patient, very, very sick. Now the patient gets back. Eventually, they have to go and operate again. And all the processes repeated again to go and check. Or let's say that, oh, this supposed to even have the CT scan and they were able to see and they say, oh, there was something. That's assuming it is available. Because we didn't even go into the diagnostics. Because if I begin to talk about the problems of diagnostics in Nigeria, why are the delays? She mentioned here that one of the scopes of negligence, whether misdiagnosis or delayed diagnosis. Have you asked yourself what causes this misdiagnosis and what causes these delays? In fact, for you to even make the diagnosis, something that will be done within, I request CT scan now, and within 5 minutes I get the result, I get it done. Then you know how much you get it done in Nigeria and what it will cost you. Do we even go to talk about the fact that patients pay? And that is why they will not present at the right time when the right thing can be done. And you find them going to tent medicine dealers, not even or should I even talk about, see, I have to, it's confusing when you ask me questions on what should be done so that Nigeria can operate on international standards. So the simple answer is that the systemic failures must be addressed. Corruption in the system must be addressed. And when these things are addressed, then you now have what it takes. Nobody is stealing the money meant for this infrastructure and operational cost of the hospital. And when nobody has stolen them, they are available. Then you can ask me, doctor, what can we now do to ensure? But everything that can be done, once these things are not fixed and I begin to talk about them, you get the point, you'll be hooked. Because you now discover, if I tell you, okay, you must wash your hand, you discover there's no water. Okay, you must use bright lights, theater light, that is, bright specifications. You notice that the one that is there, it does not even work because the power cannot carry it, or we know what is the system of our light. So you now get to all that needs to be done. But however, I'll just tell my surgeons, simple advice, try your best, continue the good work you're doing, try your best to observe the ones that can be observed at any point in time, and try to make sure that you are, you document, 2, everything clearly documented, make sure you're compassionate, make sure you're competent, make sure you're current. Current means up to date with information, what you should be doing, and then make sure that you are content. When I mean content, it may be your professional satisfaction, not just content with that meager or peanut of a salary that they pay, but the professional satisfaction, shun greed, because once greed comes in, you see yourself doing the wrong thing because you want to get more money. That is one of the ones that can actually hook you. But all these other systemic failures, when it comes, the lawyers cannot prosecute because they will see that the problem, the root cause of the problem is not you. You were actually honest, sincere, compassionate to do your work, and competent enough to do the work, but the system failed. And that is why there was something that is called negligence. So when it is like that, for my doctors and for my colleagues back there in Nigeria, I praise you because I know you're wonderful people because of the way because you are truly magicians. It is when I find the right place to practice that I found out that the system is made to help everything work. And when there is a breach, it is easy. That is what your reporting system is instant. Somebody just fill a form online. There is a form, OVR. There is a report of something that is not available. There's water, has stopped running. Is reported, but within minutes is sorted out. Whatever cost, there's a breach. It's not as if everything is perfect, but once there is a breach, this reporting system is perfect and it is already addressed immediately. Just say that this did not work today. Immediately, somebody stand up from his feet and make sure it is sorted out. But in our system, the politicians are left to run the hospital in proxy. The politicians sit in Abuja and they want the surgeon who is busy operating, reading, stress to come and be lobbying them before what should be provided in the hospital is provided. These people will not say it because the CMD must please the board chairman. The board chairman must please the presidency, and all these people are set to eat. They just want what they can. It is how many millions the CMD can give to the board that determines whether he's a good CMD that deserves to retain his seat or not. So let us be honest with ourselves. Nigerians can only fight for themselves. They should rise up and do the right thing. We are dying in droves. He talks about maternal infant mortality, Dr. Beatrice. Infant mortality, we are the highest in the world. Maternal mortality, we are one of the highest in the world. Think about our life expectancy. For a man is 53, for a woman is 55. The global average is 70, 74. What are we? Our health indices is terrible simply because the people that should defend, the leaders that should defend the people and provide for the people are interested in how many billions and trillions they will corner for their own individual pockets. The truth is that we cannot change anything much until the system is fixed. Should I talk about the anarchy in the system? The anarchy in the system intentionally introduced by the leaders to make sure the doctor is quarreling with the nurse is quarreling with the lab is quarreling with this. So you are working, for you to have a perfect outcome, you have to work as a team that are united in one purpose to make sure the patient gets best. But what happens? Because of the anarchy introduced, either through the paying method and paying system, those people are bickering among themselves. There is no unity. And because of that, you see, this one is looking for a way to make you fail. And the patient, and that can lead to a patient dying. A lot of things people need to see that we need to do something. And that thing that needs to be done, the politicians will not do it. It is the Nigerian people that will say, this is no more obtainable. My people are dying. Anybody, when you see the road, in fact, let me tell you, give me just two little stories. One of the best neurosurgeons we had in Nigeria in my time when I was training died on the road simply because there was traffic on the road and he started having asthma along the road in the car. And there was no road to carry him through. And he eventually died. There was a woman, a young woman, 30 years, a consultant to United Nations, whom I managed sometime. What happened? Something was forgotten in her abdomen during an operation of myomectomy. This is someone who came from outside the country, working as a consultant for United Nations, a young man, 30 years, just about to wed or married, but about to wed, and they wanted to deal with the fibroid before, and then something was left in the abdomen. At the point she needed to, all the hospitals were closed down, one strike, this one had problem, and was rejected in the other hospital that was open, eventually brought to a private hospital that I was trying to manage, I was managing at that point in time, and I only accepted because it was already beyond anything you can do, septic shock already, and leaking feces from the abdomen. We already know that there's hardly anything anybody can do, but I had to accept and then did everything because of the level of care given to this person. Even though at the end of the day, this patient eventually died, what was left, they had already done operation 3 times outside until this time, when it was obvious that the person was about dying. They came. I only accepted this patient on agreement that this person is most likely going to go. But they say, just do whatever you can. Since all hospitals are locked, the big hospitals are, what did I do? We brought everything to keep her alive for some time, brought those that are not even available. We ordered for them. The money was not their problem. After all these tedious 3 days, being on my foot, when this patient died, the relative came to me. I was telling me, doctor, thank you, sorry. That's what I'm talking about. At the end of the day, what happened? They insisted they must sue the other colleague. And because this other colleague happens to be a good man, it was an error that occurred because of these same systemic challenges. No light, the light came and was going on and off, and they were rushing to finish before this, and then he couldn't remember that there was, as the bleeding, he was talking that place with God. He couldn't remember there was one still left, very high, and that was the cause of the problem. He didn't do it intentionally, but he was hurrying to be able to finish before either the oxygen finish or the light goes off again. Now, is it the person you encourage? Okay, let them sue. I had to sit them down, pleaded with them. All they wanted from me is just to write the report and everything. I said, please. And based on the way I handled this patient, they told me, okay, no problem. Until today, that man didn't know, the doctor that did the initial error, till today didn't know what happened, except that she had already seen the problem. He didn't know what the people wanted to do to him. I didn't tell him. So what I'm trying to say that the system is bad and is what is causing the death of our people in droves. You go to the hospital, Because one thing is not available. You say you break. There was a video that circulated about a month or two ago of a person that was brought in ER. If the system is working, that patient who had accident will not be brought into that ER with somebody's car sitting down. Failure has already caused that man to be, the complication is already there. He can even go paralyzed simply because of the way he was sitting in that car. And then that patient eventually, the sister was standing, I don't have this, there's no this. Yes, the sister was a bit lousy, but it wasn't her duty to go into that car to bring out that patient from that place. There is paid, who may be from that locality because it's a low job that is only indigenous they give it to. And that person does not care. He's not nowhere to be found. But not supposed to go and do, whether he has waist pain or not, doesn't matter. He has to carry that patient because we are in Nigeria. So the system, if it is fixed, our people, we will have less occurrences, incidences. And if we put up all that we need to do, including the system, the monitoring, the EMR, that's the electronic monitoring, computer in every clinic, everything is entered as per real time, you will hardly have these deaths occurring or negligence issues occurring. Thank you so much. I don't know if I'm able to address your question.
Thank you, Dr. Chukwu. Thank you. We appreciate your conversation around this medical negligence. I can see your heart is vexed that we need to address the systemic failure. So we are now at our question and answer, and we have a number of questions to be addressed. So the first question is from Emanuela Shotomi. Her question is directed to Mr. Abutu. Mr. Abutu, Emanuela's question goes this way, that market operators go on to switch off their generator. They go on to switch off their electricity supply in their shops to discourage NAFDAC officials to inspect their shops. Now, what can NAFDAC do in that effect? Mr. Abutu, are you there?
Yes, I'm here.
Okay.
We put up with a lot of issues with people who market the products that we regulate. Like she has said, there are times we have been to one or two facilities and then people would let their dog out to scare inspectors. So beyond putting off their light and all of that, once the facility is open, we will improvise to be able to carry out inspection. Although if the lights are on and everything is in place, it will facilitate better inspection. But again, we improvise and ensure that we do our job. But like I said, when all is said and done, where you have issues relating to obstructing you from doing your work, there are provisions in the law that allows you to come up with a charge for obstruction of officers to do their job. So in serious cases, yes, we prosecute people who do that kind of thing. However, there is need for law review, which we are also trying to push. We're trying to push the National Assembly to bring up some of the penal provisions up to modern times, reality, so to say, because what we have right now for obstruction of officers is not anything serious to really deter them. However, again, that is all that you have in terms of prosecuting people who obstruct you. So what she has described is obstruction of officers to do their work. And when that happens, you improvise, find a way to do your work. And then if you think there is need for you to deal with it through the court system, again, you can file a charge for obstruction of officers. Thank you.
Thank you very much, Mr. Abutu. The next question is addressed to Dr. Beatrice Ezenwa. And the question goes, is there any justification for overdose? Because you mentioned while speaking that before placing blame on anyone, the doctor should look into the reason for such overdose.
Okay, thank you for the question from the audience. Okay, there is no justification for an overdose, actually. However, it's assumed that you have identified, you have verified that there is actually an overdose. Okay, once it's verified that there is an overdose, there is actually no justification for it. But what I meant is that before you you conclude there is an overdose, you need to know what actually caused. Even if there is an overdose, why did the person give an overdose? Is it because the person who prescribed it was a wrong prescription? So, and he's just carrying out whoever is giving the drug is just carrying out the dosage they saw. Okay, so the overdose itself may not be originating from the person who gave the drug. It may be originating from the prescriber. It could also be from the fact that, okay, in the course of mixing, okay, the person didn't calculate too well. Our moderator was saying the other time that in newborns, you should not give them 2.5 ml of paracetamol or more than that. What is it? Were you calculating in meals? Like I said before, you don't really, we don't give drugs to children like that. We give them based on their weight. So that 2.5 ml depends on the formulation that came. Okay, so if the formulation came in such a way that 2.5 ml is giving you 10 milligram, there may be another formulation that comes and 2.5 milligram, you only get it with 5 ml of the medication. So you need to know which one it is you're giving. So for example, this person that gave overdose, was it that the formulation that each time we prescribe, we usually ask the doctors, we like prescribing in generic drugs, okay, names. You don't go and say, give, for example, go and give this particular drug, let's say augmentin, or you give this one. In another, the one that is available in that pharmacy may not be augmentin, but because you have said give augmentin, and augmentin comes at particular formulation, the one in that pharmacy may not be in that particular formulation, not the same milligram. There are some drugs that may come like, okay, maybe 1 ml will be 10 milligram. In another formulation, it will come 1 ml will be maybe 30 milligram. So if you've given that and given the generic and give 2.5 ml of Coartem, and the person now go and get another brand and get something like Amatem or something, is it going to be the same formulation? Is it the same quantity? So that overdose that we are talking about, you need to investigate. How did it, and that's why the root cause analysis is very important. Why did it come to that? Okay. So, but by the time you verify that there is an overdose, there is no justification for an overdose, but you need to know what caused it. It may not be actually the fault of that person, but when we are talking about children, whatever you do, you need to take responsibility. But why did it come to that stage is what one needs to find out. Thank you.
Thank you, Dr. Beatrice. Because there is no time on our side, I will be having your final word so that we can be, fast. Give us your final word.
Okay, thank you very much. So this presentation, this discussion is really, if we continue, there are so many things to talk about in the system that is causing the problem. Dr. Chukwu's passionate presentation, really, he said everything. Okay, you are working, things that will enable you to do a good job may not be there, and we are all improvising. Sure, the second name for Nigerian doctors is improvisation. You rarely see anybody who is not improvising in Nigeria, okay? So that you can, because like he said, the patient is in front of you. What do you do? And when you tell the patient that, oh, this one is not here, you're going, they're likely going to go, and they may go and meet a worse problem. Okay, so you improvise and improvise. So my last, what I will want to do is that all of us need to keep on talking to the government, because if the system is healed, everything will be done. And we will be working like Dr. Chukwu is now enjoying himself in, in Saudi Arabia, where things are working. But we keep saying if these things are working, where things are working. But it can work in Nigeria if all of us are consistent and if all of us are sincere. But it must start from those who govern us, from the management, from government, and we as individuals. Of course, we need to clamor, because if all of us keep asking the government, do this and do that, one day we will get one who is going to do it. Okay, but all of us are, you will see it doesn't concern me until you don't know when it will concern you. Okay, health workers are going, nobody is talking. The ones that are remaining, people are overworking them. Now, so many people, in short, now we've started a new round of strike, because nurses, I think, globally are on strike from today. The doctors are warming up. The other health workers are also warming up because of one systemic problem, challenge or the other. Let governments listen. And health, where there is no health, you are not going to make wealth. They said health is wealth. So we should accord it the priority that it deserves. Thank you very much.
Thank you, Dr. Ezenwa. So we have 2 more questions addressed to Dr. Chukwu. Dr. Chukwu, I hope you're available to take this question. The question goes this way: is there anything doctors or medical practitioners should do to improve the health system other than leaving the country? And the second question is, would you defend or would you testify against your colleague who was negligent in the course of his duty?
All right. Thank you, Ifoma. Yeah, that question is expected because you had asked it in a different way and the person is asking it in another way. Is there something the doctors can do? I'll ask a question now to you, Ifoma, the lawyer. When will NBA, NMA, and all other PCN or PSN, all other NAM and others come together and insist that the right thing be done in Nigerian health sector? In fact, in the Nigerian system as a whole, because the day NBA and NMA come together, not as opponents, but as a team that are determined to fix Nigeria, they will bring in NLC, they will bring in the petroleum marketer, they will bring in every other person, because these are the leading organizations that understands the problem in the system. And if they can come together, I assure you, it is the best they can do to fix the system, because the people, the powers that be, will not allow you as an individual, as a soldier. There's nothing you can do. Let me tell you why it is almost impossible for a single doctor or just a group of doctors to be able to do anything. See, as a resident surgeon, I will be there. Remember that my head of department is a political appointee in proxy representing the CMD and the management team. And the management team is representing Abuja. So whatever you say, if this is not available, your boss will tell you, I don't want excuses. Do whatever you can. Make sure that work is done. It's the way they sound. But that will not fix the problem. They don't want to address the problem, because if they address the problem, they will expose the people who are eating the money that will make that will make the system to work. So that is the problem. So there's nothing except all of us coming together as a people. See, I am one person that never, let me now jump into your next question. Other than leaving, I was one of the persons that by the day I graduated, within 1 year plus, I wedded. And during that, my wedding, I had 3 offers to leave this. I'm talking about something almost 20 years ago, almost. Now, I had offers to leave the country. And I looked at these people giving me this offer, one from in-law, one from my uncles, one from this. All they want is, don't stay here with your wife. You people should not stay here, leave the country. I said, if all of us leave, who will stay? I ended up spending more than 16 years in Nigeria. And those 16 years, I kept believing that things will change. I kept believing that I am patriotic and Nigeria has to change. I'm not going anywhere. After all this, it got to a point that I had to tell myself, after getting to the peak of my career, becoming a fellow in surgery, general surgery, I felt, what else will I be here? What else? There's nothing. Everything you want is not available. You want this, not available. Even the advanced system, the advanced practice that you want to go into, you don't have the opportunity. You just remain there and be interfacing people who are frustrated by the system. You are people that are crying. Do you know that initially I had a hospital? And in that hospital, more than the people that paid their bill, that did not pay their bill, were more than those that paid their bill. Why? Because they will come as emergency in the night. You wake up and start work all night, attending to them, spending your resources. In the morning, maybe you have to refer to a bigger center. They will tell you, thank you, doctor. You want them to pay, they are reserving the money they will use to pay in the teaching hospital where they're going. And they will tell you there's no money. You continue that system and you are frustrated. You are a doctor. I also married to a doctor, and both of us are there, but we cannot afford basic needs of life. We can't take care of the people. Let me be honest with you. Your paying salary at the end of the month, what is remaining after all the tax and everything, may be less than 200,000. You know what it is? Your generator, your fuel, your children's school fees, house rent. You see yourself a doctor and you are a beggar. At the point, I told myself, I can't continue to live this kind of life. I suffered to make sure I get to where I am so that I'll be able to be a little comfortable and be able to help those in need. And then those in need, I can help. So going out is not the best for anybody. Like me, I never wanted to go out. I was forced to go out by the system. I won't tell you the other one. I wanted to, okay, let me establish a business that will help solve the problem, the debt of unavailable resources in the health sector. I wanted to open a business that will produce medical supplies. As a doctor who is working in the federal institution, my wife working in the federal institution, we approached the body that's supposed to give us money to develop industry. After all the beautiful plan, I won't tell you what their responses were. They wanted me to provide things that even if I work for another 30, 40 years, my salary all put together cannot provide such things. So what will you do? You must, no matter the dream you have, and that company would have been the first in West Africa and would have the potential to transform the health sector. To be honest with you, some of these things we are calling these are not available, this is not available, won't be there if I was supported. But what happens? It's frustration. You have the dream, you have the intelligence, you have the skills, but you are frustrated. Nigeria does not support excellence the way it is now until we need that country be reset. It has to be reset by somebody who is sincere about resetting Nigeria and cutting the cost of governance and make sure that Nigeria begins to look like other countries. Imagine when Ghanaians are sending you away. Imagine when South Africa is sending you go home. Britain, UK is telling you go, very soon you go, you leave. America is telling you go. Where will all, imagine the suffering. Let me not go for it. What was the second question? Let me please remind me because I think I've...
Whether you can testify against your colleague in court where the disciplinary committee has found him or her guilty.
Definitely. Let's be honest. One thing I believe in is honesty, truth, integrity. When I gave that recommendation, I said there's this DC4 principle. It's my personal principle. I developed it. I keep it in my mind. I work with it. What is it? Documentation, compassion, competence, current, contentment. Honesty is something that you must always say the truth. If I'm invited to testify in the court, the law is even, I'm bound by the law to testify. What I can never do is to falsify information. I can't do that. I will definitely say the truth the way it is. And I can tell you that I will present it the way it is. I may present evidence of the failures that may have necessitated to this. Let me give you an example. You have a doctor who is there about to enter to do an intricate surgery. One example, a few years ago, Christmas Day, a young man driving his car. Somebody came to his car, put a gun on his chest, shot the gun. You know, the casing of the cassette was inside his liver. The pellets passed through the liver, through part of the lung, the liver, then shattered everything. And he was at the point of death. They rushed to the hospital. It was on a New Year day. I was on duty in the emergency. I was covering the emergency and I have to operate. When this patient came, it's obvious that if nothing is done within few minutes, this patient will not be alive. And what do? This one is not available. The person that's supposed to do this is not available. It's a New Year day. And you call, phone is not going. You cannot do anything alone. You call this one, other people that are not, they will tell you, sorry, that they are not on duty. You know, what do? Eventually, we were able to mobilize very other compassionate doctors who were not supposed to be there. And we went into within 30 to 40 minutes. The life was saved at least for close to a week. He had opportunity to settle his things, we didn't have things to repair liver and all that, but we were able to pack them together with pledges and threats and manage just to keep him alive and know if a better thing can happen or some miracle can happen, you know. But along the line, after all that was done, he was able to live for 1 week, had his time to do his will, interact with his people and everything. And then eventually, on going to now remove what we used to pack all those things, we knew that he may or may not make it. These are scenarios you see. But those people, there was one of them I called the CMAC and said, if this person is not punished, I will not help and push patient again. I have to push that patient from emergency to theater. It's not my duty. I have to go to every department. So it's not our duty. But we did it. But that particular case, I called the CMAC. I said, these ones are supposed to be on duty that didn't come. This didn't come. If nothing is done, I will never. And actually, to be honest with you, the CMAC instituted and that person, in fact, the disciplinary correctly. So if it is testifying against someone who's supposed to do things and didn't do it, or who does the wrong thing, it was obvious, or a colleague who commits a criminal thing or, you know, a malpractice, which is done intentionally, to be honest with you, I'll be one of the first that will testify against such a person because I preach excellent character. So you must do the right thing. So, and many people know that. So if it is testifying, I will definitely testify. And I encourage everybody to testify against wrongdoing. This is one of the ways we can change the system. The right things must be done at all times. Thank you.
Thank you very much, Dr. Chukwu. Please, in 1 minute, can we have your last word?
All right. Let me say this last word by saying that the problem in the Nigerian health sector may be hydra-headed, but the solution is not rocket science. In other words, something can be done. If we can increase health sector funding to that 15% Abuja declaration that was initially mentioned, if we can restructure the regulatory bodies and eliminate all the interferences from all these multiple regulatory agencies for different departments and streamline them, you will see that because people know that there are surveillance systems watching them, their behavior in the work front will change. If we can establish mandatory malpractice insurance for all health workers, mandatory, it will help. Then if we can develop, you know, a kind of reporting system, streamline it so that there will be, the money that is used to buy, street lights or to renovate the government house in Oyo State, enough, if shared between all the hospitals in Nigeria, I tell you that, to be very honest with you, they will have telephone. And they will have numbers, they will have things. Finally, at the practice level, I'll say we need to install these surveillance systems. It's not too much. In the critical areas like emergency departments, outpatient clinics, and our operating rooms, so that at each time, whatever happens will be seen. It will make the workers to be able to behave the right way. Then we should also require continuous professional development, like our CMEs, that people just log in. There will be a way to monitor those who are involved and ways of monitoring, continuous training exercises, conduct regular clinical audits. What is done in audit is that every week or every 2 weeks, let us see, why did this person develop this complication, this morbidity? Why did this person die? And is presented with honest intention and plan for implementation. Not after audit, nothing is done. Finally, we must make sure that we work as a team. Those anarchy that is introduced by our leaders, please let all the health workers understand that those were done to divide them. Then they should refuse to be divided and be united for the welfare of the patient and for the improvement of the system. And finally, I call on NMA, NBA, and all other professional bodies to come together and insist that the right thing be done by the government. And if it is not done, they can, if it is for 1 week, lock down the country and insist that the right thing be done. You see, sometimes when I speak more like an activist, but that is the only way things can change. So that's my simple advice. And to the government, I will advise that they become sincere with the people. They will not carry all this wealth that they gather and go anywhere. The day they stop breeding, like our former president just did, everything they've accumulated will be wasted, either by foreign people, strangers, or their own children. There's no need acquiring all these resources. Why your people die on daily basis because of poor resources, poor equipment, and general systemic failure. So many things that ought to be done, you are not doing, but they are gathering money and competing who will gather more resources to themselves. I stay in a country where people do not gather things because they believe in the system. The system is set to provide for them, so nobody is greedy in that way. So I think that would be my final advice. Nigerian system, though hydra-headed, the solution is not rocket science. With determination, we can succeed. Thank you.
Yeah, I agree with you. The solution is not a rocket science. Is simple. So I'll have to come to Dr. Ramalan. Dr. Ramalan, please, can we have your final word? Dr. Ramalan, are you still there? Okay, Dr. Abutu, can we have your final word?
Well, you've been speaking with doctors for a while, so you are not mistaking me for a doctor. I am not a doctor. I'm a lawyer. I just want to say that as an organization responsible for ensuring access to quality, safe, and efficacious medicine, I recall that Dr. Chukwu mentioned something about cutting corners. That is something that we do in Nigeria a lot. And then Dr. Esenwa also mentioned the Mypekin case. And as a matter of fact, in that Mypekin case, I was part of the team that prosecuted that matter. What we found was that raw material, particularly the chemical needed, diethylene glycol, which is used in that kind of medicine, was actually someone who is of a secondary school holder, but from a source that is not actually known in a container that is not the original. And so in buying diethylene glycol, because both of them look the same, almost the same, but ethylene glycol, that caused that problem. And equipment were not working for them to actually test and see all of that. But because of this cutting corner here and there, ethylene glycol got into the product, and then again, production manager, quality control officer, all of them just gave the go ahead for product to go into the market. Then the product went into the market, and then we lost about 84 children. And so it's about cutting corners. But we cannot be present everywhere at every point in time. So what we also advocate is that people should acquaint themselves more with the guidelines and all of that. And then also with the knowledge of production, the knowledge of this, because apart from production, products can also become substandard even in the course of distribution. Because for instance, where it requires cold chain storage, and then it is kept in a place where maybe just locked up in one warehouse, like we saw recently in Aba, where you have one whole building about how many upstairs dedicated to storing products. They don't care about this kind of storage system and all of that. So we'll just advocate more of compliance and then working more with the agency so that we will all save our population from instead of helping their health challenges. So on the whole, I just would advocate for more compliance from our stakeholders. Thank you.
Thank you very much, my learned senior, Mr. Abutu. Thank you for the work you're doing in NAFDAC. I don't know if Dr. Ramalan is still available. Okay. On that note, I'll be calling my colleague, Mr. Chukwulobe Udenna, Executive Senior Associate at Ulisangbakoba Legal, to give us a closing remark. Okay, we are waiting for Mr. Chukwulobe to give us a closing remark.
Hello, panelists. Okay, my name is Udaina Chukwulabe. In fact, if we're in an open place, I don't know how I would have asked everybody to applaud the panelists because they've done a very good job. I don't know if everybody is as confident as I am, but from the way Mr. Benjamin has and Dr. Benjamin has spoken, I feel like going into the medical theater to carry out an operation, because I feel that as it stands now, I have the qualification of being a doctor or a medical practitioner. That's to show how well we are greatly enriched. But I know many of us will not be willing to allow me operate on them. But I'm very sure that I'm going to do a very good job. Once again, I want to applaud everybody that made our time, most especially the panelists, for enriching our knowledge, because this is a very important area that has continued to affect us generally. Most time when you want to understand the impact of discussions like this, if you have not been confronted with one or two medical issues, because I could recall when my dad was very ill, I know how we tried our best to see who can give him a very good medical attention. Sometimes we go to the hospital, discover the entire ward is filled up. You carry a very sick person running around, no hospital to admit. You find out that most of the hospital is understaffed. It's understaffed, just as most of the resource person have actually said. It's a very sorry situation. And that is why I share the sentiment of Mr. Benjamin. In fact, I can see how the way he's sounding shows that he knows how the system is in the country. But as a country, we'll continue to get better. Rome is not built in a day. Rome is not built in a day. We'll get there, hopefully, with the assistance of persons like Dr. Benjamin in the diaspora, coming to Nigeria to share knowledge and impact others here, and trying to see how we can influence the government to do what is necessary. I know we'll get to the promised land, but we know that in Nigeria, just as you rightly observed, issue of corruption cannot be nipped under the bud. But we'll continue to do our best and hope that our leaders continue to hear us, and one day they will do the right thing. Once again, on behalf of Olisa Abakoba Legal, I have the honor of appreciating the panelists and all the others that have joined us far and near. I want to appreciate you for your time, and I believe that we all had a very fruitful discussion. And I know that we'll go out and we'll continue to perform wonder. And with what we've heard, it is our duty to go and preach and spread the good news so that it gets to the ears of the authority, so that we'll continue to get things right in this country. Once again, I appreciate you all. Thank you.
Thank you very much, Mr. Chukwulobi, and thank you once again to our esteemed panel of speakers. We appreciate you. Please, when we call you next time, do well to answer us. Thank you, our dear distinguished participants. Thank you for joining us in this epic conversation. Do enjoy the rest of your day. Bye.
Bye. Thank you so much. It's an honor and pleasure being with you.
Thank you. You're welcome.
Everyone, my name is...
Thank you, and goodbye. Thanks for inviting me.
Thank you. You're welcome. You're welcome, Dr. Beatrice. Thank you, Dr. Abutu. Thank you, Dr. Narama.
Thank you, Olisa Agbakubalo fam. Grateful to have been in the part of this program. Very enlightening. Thank you so much.
Welcome, sir. You're welcome, sir. Bye.
And Tech Department. Hey everyone, my name is Okundai Mary Cynthia, an associate at Olisa Agbakubalo Legal.
Hi everyone, I'm Emmanuel Aguilario, an associate at Olisa Agbakubalo.
With an enviable track record of more than 40 years of experience as a legal service provider in Nigeria, OAL has greatly contributed to the jurisprudence in Nigeria. At OAL, we understand that the legal landscape is ever evolving and our clients require not only expertise, but also innovative solutions. With a team of highly skilled legal professionals, we are proud to offer comprehensive legal services tailored to meet the unique needs of our clients. With an enviable track record of more than 40 years of experience as a legal service provider in Nigeria, OAL has greatly contributed to the jurisprudence in Nigeria. At OAL, we understand that the legal landscape is ever evolving and our clients require not only expertise, but also innovative solutions. With a team of highly skilled legal professionals, we are proud to offer comprehensive legal services tailored to meet the unique needs of our clients.